views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Allergic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Hi, my name is Dr. Alpen Patel, and I currently serve as the AAOA President. I'd like to welcome you to the AAOA Zoomcast Series. The pandemic crisis has really turned our lives upside down, and its impact has been far-reaching to say the least. As our states and practices reopen in the near future, we prepare for the new normal in healthcare. Today, we have a distinguished panel, and we'll introduce those panel members in just a little bit, but we'll be discussing how to jumpstart your practice in this new era. Let's start with these introductions, including conflicts of interest, as well as your current practice setting. I'll go ahead and start us off. I'm your moderator, Alpen Patel. I have no conflicts of interest to disclose, and I'm in a single specialty private practice in the Baltimore area. Dana?
So my name is Dana Crosby. I also have no conflicts of interest to disclose. I am in an academic practice at Southern Illinois University where I'm the residency program director, as well as a rhinologist and endoscopic skull-based surgeon, and manage the otolaryngologic allergy practice.
Doug?
Hi, my name is Doug Dawson. I practice in Southeast Iowa, and I have no conflicts of interest, and I practice mainly sleep medicine, rhinology, and allergy as well, general otolaryngology.
Gavin?
Hi, I'm Gavin Setzen. I'm an independent private practice otolaryngologist with focus on rhinology and allergy. I am in upstate New York. I have some conflicts in terms of being on the advisory board for Stachler ENT, and I'm a minority investor in IoTech International and involved in clinical trials for Clarifix and Latera. Thank you.
Rob?
Hi, I'm Rob Stachler. I am a otolaryngologist from Detroit, Michigan area. I'm actually in the north of the city. I have a private practice that I started 2.5 years ago. I have no conflict of interest. I've been involved in the AAOA for quite some time, been on board and held numerous positions. I do mostly general otolaryngology, laryngology, and otolaryngologic allergy.
Wes?
Hi, I'm Wes VanderArk, and I am in private practice in Harrisburg, Pennsylvania. I do general otolaryngology as well, probably focusing a bit more on rhinology and otolaryngic allergy. No conflicts of interest.
Chris?
Good evening. I'm Chris Vickery. I'm in private practice in Augusta, Georgia, 2 hours east of Atlanta. We're the second largest metropolitan area in the state. My practice consists of 14 otolaryngologists, and we have 3 locations that we rotate among. I'm part of the practice COVID committee, and I'm part of the tracheostomy response team for the hospital. My practice is really general otolaryngology with rhinology and allergy, and I'm boarded in sleep medicine as well. And I have no conflicts of interest.
Very good. So I'd like to thank the panelists for participating in this Zoomcast. Let's go ahead and start the Zoomcast panel discussion. We'll start with our socioeconomic chair, Doug Dawson from Iowa. Doug, you've been in the clinic setting now for at least a week or two, from what I understand. What are you doing differently in that setting, and has your workflow changed compared to the pre-pandemic period?
Yes, it certainly has. So I would say the biggest change is a reluctance. I think Gavin had mentioned this, reluctance of patients. I've been probably 10 business days, we've had patients back. I started out with 21. I had 3 no-shows that day. And then since then, I've been averaging in that 15 range or so. mostly live. Epistaxis has seemed to rear its head this last 2 weeks. I've had 3 in one day, a couple almost every day. And as well, we've been changing how our workflow for patients entering. So first of all, patients are called the day before by front office if they are not acute or like the epistaxis patients and emergent. Secondly, they have all that registration issue taken care of. They're informed to call the office number, a special number, when they arrive in our parking lot, and they're again kind of brought into the EMR at that time. They wait in their car. Our nurse then goes out, meets them at the door, waves them in, whatever, and then they go through the waiting area. We have a waiting area. It's nice, it's large, but we share our waiting area with an orthopedic surgeon. And as you know, on a regular day before COVID, it would be 50 patients in an afternoon, and no joke. So it could be quite crowded. So we walk them right through there. We don't have them wait in that area. They come right back to a room. But we've changed in terms of the volume we see of patients and the timing between patients, because it is taking longer for that front office routine, as well as the nursing with their screening questions and making sure they're not ill, taking their vitals, as well as measuring temperature and things. So it's changed things remarkably. Everyone wears a mask all the time. We have face shields anytime we're going into any kind of procedure. I pretty much keep it on most of the time, except when I have troubles breathing, because I really don't like this mask thing. But otherwise, just really pretty much keep that as a standard PPE. I think we could stop there. That's kind of the beginnings of things. We certainly have reduced volume, increased contact time in terms of processing a patient, and then as well as checking them out at the end.
Okay. Rob, you've been in private practice for a couple of years, as you mentioned, and you're seeing patients live now instead of just telemedicine in the solo practice setting. Are you doing anything different than Doug, anything unique, or anything that you're doing differently than before the pandemic crisis broke out in February?
I have a small waiting room. So I have about 8 or 9, at the most 10 different seats. So I really don't even use my waiting room as a place for people to wait or congregate. I'm telling people to stay in their cars, and we'll call them to come in. We put them right into a room. If there's more paperwork that needs to be filled out, they fill out in the room. If there's a chance that there's another person in the waiting room, I have them wait outside our entry door, and they're not to come in until the room clears. Of course, it takes us a long time to wipe everything down. We have 3 exam rooms. It's not a huge office. My wife, who's the office manager, will also assist in cleaning up things and wiping everything down to help with the MAs. But we do a heck of a cleaning our patients before we even bring them in. So if there's really any question, if somebody has something, then we double down. Everybody has a mask on. If I have one lady say that she didn't want to bring a mask, she's been excused from having to use a mask. She's got a 17-year-old kid. She's supposed to come in next week. I put a new sign on the door: no mask, no exceptions, no admittance, period. So if you don't have a mask, you're going to go see somebody else, because when you come see me, everybody has a mask on. We only allow one person to come with, assist somebody. The days of having 3 or 4 people with every patient are gone. That's just not going to happen. And we take our time in wiping everything down. I very judiciously decide who I'm going to scope. I do have plastic face shields that I use. My PPE is not a N95, because I still have very limited amounts of N95s. So I'm really saving those for people that I really suspect have a problem. I do have an Envo mask waiting on order. It's supposed to be coming in. I do have other N95s on back order. So my biggest issue is having a ton of PPE to go around.
Okay. For the other panelists, what are you doing as far as the appropriate PPE for yourself when you're scoping or when you're not scoping, as well as for the staff? Rob mentioned the non-N95 mask that you're using for most patients, as well as the shields. I've been using the K95s and the shields, and I'm having a very difficult time removing earwax and scoping patients in the office, partly because it's not fitted for my face. It's something from a Canadian company that made these K95s, since the N95s are a little bit harder to come by. And I think there's a little bit of a leak, and then the shields are bulky and they're not conformed to my eyes and my face. So sometimes I get frustrated and just pull the damn thing off, even though it probably is not in my best interest or the patient's best interest to do that. So what do we do as far as PPEs go? Do we also wear a gown? Do we wear, hat covers and things like that? Anyone with any ideas on this as far as other panelists besides Doug and Rob?
Well, I would say for patients in general, in the room, sanitizing one's hands, washing them, going into the room, wearing gloves. For a low-risk patient without a so-called aerosolizing procedure being performed, I'll typically wear a regular surgical mask and eye protection. Typically an N95 in the event that a flexible nasal laryngoscopy or a rigid nasal sinus endoscopy is being performed, not using an atomizer, but using a cottonoid or pledget with oxymetazoline and 4% lidocaine. I'm also using molecular iodine on the swabs, anecdotally, to try and reduce viral load, for example. I found that to be helpful. I think things like gowns, foot covers, and hair covers are optional, especially in the case of epistaxis or splashing or droplet spread being a concern, but certainly eye protection as well. And I think it's situation dependent. It's a matter of resource availability. And I think what one has to be conscious of today is what your burn rate for PPE might be, especially as you ramp up, because that availability has to be paced. And so we also reuse the N95, and I use oftentimes a regular surgical mask over that to preserve it and get a little extended wear, and can talk a little bit about other techniques for preserving PPE a little later on if you'd like.
Are you requiring any of the staff to wear PPE or masks at all, or just the patients and the providers?
So every patient wears a mask, even young kids, little kids, and staff similarly. The staff will wear gloves and a regular mask when they are cleaning or decontaminating, sanitizing, sterilizing equipment that's been used, particularly scopes. They will use an N95 and eye protection as well.
Okay. Is anyone else doing anything differently as far as scope handling or sterilization, or following what Gavin said as far as just appropriate PPE, whether it be an N95 and eye protection?
Yeah, I've stepped away from using the atomizer at all. I do the same thing that Gavin uses, is a pledget with pontocaine and neosynephrine on it. Again, just to try to reduce any risk to aerosolize any particulate that might be in the nasal cavity or nasal pharynx.
Do you use the iodine?
No, I don't, but that's a good idea. And I've seen some information about using, or even considering having patients like gargle with the iodine, mouthwash solution, or even maybe potentially rinsing their nose or flushing their nose with something like that to reduce viral load. Although I'm not sure, I haven't done that yet.
Gavin, do you have a concentration or anything for that?
So I use molecular iodine, and it's diluted with the oxymetazoline and the lidocaine, and pretty much in equal parts. There's no data against COVID-19, but it has been shown to be efficacious against SARS and other bacteria and viruses. So, you know, a lot of this is anecdotal, and there's no scientific data currently on COVID-19, just to make that clear. But theoretically, it's widely used in the dental field for the oral cavity. And so there are a lot of anecdotal reports on various blogs and so on regarding either nasal and or oral use, intraoperative, skull-based prophylaxis. And povidone iodine was used initially in the UK as early as March 20th. There were studies reported there.
What is the mix exactly?
It's equal parts depending on how you prepare and what kind of volume you use on your pledget. So there's no magic to the mix. It's probably a couple of cc's of each.
So Gavin, you did talk about reusing these PPEs, especially the N95 and these KN95 masks, which aren't cheap, right? About $8 a mask, and we rotate them in paper bags depending on the day of the
Sure.
week. But is anyone or different as far as the ability to reuse these KN95s or N95 masks without obviously ruining the integrity of them so that they continue to function as far as filtering microorganisms and such?
So because of the cost and scarcity, we looked into that, and one of my partners is a boarded sleep specialist, and turns out one of the CPAP device cleaners, which uses UVC, has been shown to be effective against SARS-CoV, not necessarily 19. But what happens with the UVC delivery is it's absorbed by the RNA and the DNA bases, and they basically form this non-pairing base, and it deactivates the virus. And they've shown that within about 5 minutes, this machine called a Lumen, it's got a little tray, you open it, you can put the K or the N95 or whichever mask it is in there, and in 5 to 6 minutes, you can sterilize it with 400+ fold reduction in terms of infectious viral load. And so it's the UVC light that inactivates the SARS virus. There were a couple of studies, one in 2004 and one in 2015, in the Journal of Occupational Environmental Hygiene. Now, at times when pandemic issues were a concern, and they showed that it can effectively kill the virus without any significant effect on the filtration performance. But over time, there is some degradation in the quality of the mask, and so you have to monitor that over time, but no effect on flow resistance, for example. So we've been doing that, and in addition to wearing a mask or a cloth mask or a surgical mask over it, we've been able to preserve things like the N95s, which are costly and very difficult to come by. So that's just one option.
Okay. So we're obviously surgeons, right? And we perform procedures in the office, in the ambulatory surgical settings, as well as at the hospitals. I'm not sure how many of the panelists have started operating again, but I'd be curious to know the experience you've had now that we're going back to the operating room, and any new protocols or procedures that might be in place, especially in the ASC and hospital setting. And then, is this going to shift the volume of cases that we do in the office, either doing more of them in the office or doing less of them because of all the precautions that may be necessary with patients, including possibly testing these patients, adults and maybe even some kids? So, Chris, any thoughts on that?
Yes, our governor has very famously eased restrictions for the public, and part of that is a phased allowance for the resumption of elective cases. And so we actually started today in our surgery center we chose to begin with only myringotomy and tube patients to try to keep things straightforward and streamlined, with all staff wearing PPE. And I think we did 5 cases today. Just like Rob was mentioning, the flow of patients is much slower than what you're accustomed to, just to allow for all the precautions. We did COVID test everyone approximately 48 hours prior to the case, so that we knew we were dealing with all negatives. And all staff were wearing N95s in the room, and anyone starting an IV or involved intimately with patient transport, like carrying a child. And they were gowned and gloved as well. We've in the discussion and the trial runs for this, the real gorilla in the room, as we've endeavored to start this or restart this, has been the anxiety component for the staff. It is absolutely very much a big part of moving forward, and as we attempt to get back to what will be our new normal. And I urge everybody not to discount that component. But it's early, and we're still learning.
Dana, you're in an academic setting. Not sure if you guys have started operating again, especially for elective procedures, right? The non-urgent cases. But are there any plans in place on how you guys are going to approach the otolaryngology surgical patient? Are we going to be able to be prioritized compared to other specialties, given that there's going to be a backlog from 2 months of not operating, even if you go 6-7 days a week and extend the hours from 7 a.m. to 7 p.m., what's going to be the new norm at Southern Illinois University?
Yeah, so I think a couple things. I think, first of all, we have been a little slower in Illinois to reopen than some other states, but as of May 11th, there is a move toward allowing some elective surgeries, but the Department of Public Health has made it so that every hospital has to have an advisory board that reviews every case that is potentially going to be put on the schedule. And so with that, they request the kind of grade of the case when you submit a case for consideration. And based on that, they basically tell you if you're allowed to do it or not. And so they're really still considering more, at least semi-urgent cases rather than purely elective here. And so we're really still, I think it could be a little bit before I'm doing sinus surgery or nasal polyp cases again. I think I get the sense that those are going to be some of the last cases to be allowed, given they are quality of life cases, and paired with the potential high risk of the aerosolization that occurs with those cases. I think that the hospitals are going to see those as something that would be one of actually the last in line to be restarted. And a lot of what we're doing, of course, given that this is all in the setting of an academic institution, a lot of the rules and regulations are kind of being handed down, and then we have to figure out how we can fit into that. And so we are next week going to slowly start seeing patients in clinic again, as we have not been seeing live patients. So I'm a little jealous hearing that some people are actually getting to see patients. But with that, we are all of my partners, we're going to pre-screen all of our patients and determine which ones truly need to be scoped, still considering the limitations of scopes and the patients who truly need those scopes at this point in time. And if they do need a scope, we are actually going to test those patients as well before they come in, 72 hours in advance. So they will be COVID tested before getting a potentially aerosolizing procedure, even just in clinic. So that's one of the big things that we've been working on this week, is getting that set up.
Gavin?
I was just, apropos of that comment, and when one thinks about return to the ASCs and you're doing COVID-19 testing on clinic patients, what is the availability and test reliability and so on in your area? Because I think it's going to come down to local, regional availability, cost effectiveness, and reliability.
Yeah, so that's absolutely correct. I personally, I think it's great that we're going to be testing patients before they come in. Does that mean I'm not going to wear PPE when I scope somebody? Absolutely not. I personally don't trust the test enough to say that that's enough for me to put myself or my staff at risk and not use PPE. And so when having this conversation, I've personally kind of said, you know, what is it really changing ultimately? Unless we really did get a positive outcome on that test, then we wouldn't have that patient come in. But a lot of times there are a lot of false negatives. It depends on the test. It depends on the predictive value in your area based on the density of cases in your area. So there's a lot that really factors into that. And so I don't think that it's necessarily a widely employable way forward. I think you really have to take into account those exact things that you just mentioned, because those have kind of been on the forefront of my mind. You know, and just this past week, I have been asked to be the one to teach how to properly do a nasopharyngeal swab and make sure we're getting as good of samples as we possibly can, instead of just kind of maybe sticking the swab into the nose and maybe getting a sample. So, you know, I think we're trying to do what we can to get accurate testing, but I still think even with that, there, you know, we know early on in the disease process, 5 to 7 days, the viral load in the nasopharynx is probably at the highest, but later on in the disease that may decline, and we may miss, or early in the disease, we may miss a positive patient by swabbing just the nasopharynx. So, you know, there's a lot that factors in, and I think just like, you know, you've said, we're still learning about this, and there are so many unknowns. And so I think we're all just kind of giving our best educated guess, hopefully.
One of the ASCs that I work out of is planning on testing all patients down to age 12 a few days before any elective procedures, but they're also recommending testing of the surgeons as well, in addition to the patients, prior to the surgeon being able to operate at this facility. Have any of you been tested for that purpose yet?
They're doing a serology study at Beaumont on all the providers, and I have to go in to my chart at Beaumont and get my blood drawn, because they're doing a large 40,000 person serology test, and the window to do that is the end of this week. So I'm going to get mine done.
While there may be guidance coming from specialty and national academy organizations and so on, I think it's going to be supplanted in large part by what happens at the local level, and Department of Health and state guidance, and then hospital guidance and ASC guidance, because every policy is going to differ, and that's really going to govern how we were able to move forward.
And many of us in private practice have more control of our settings in the office setting than we do obviously in a hospital or ASC, unless we have some physician ownership. Having that knowledge and being able to control your workflow and your environment and ensure safety for your patients, your staff, and yourselves, are any of the panelists considering either learning new skill sets or doing more, including polypectomy, sinus surgery, septoplasty, or even a whole host of other rhinologic procedures in the office setting, because of the issues that might come up with inefficiencies in ORs in the ASC and hospital setting, or the testing requirements, or maybe not having adequate PPEs, or anything else, just not being able to get some of those cases on for months?
I am not currently thinking of that, but and in fact, I would actually probably think the other way and not want to do those cases in my office, because when the patient's asleep and they're intubated or their airway is controlled, then they're actually not breathing, and so they're not going to aerosolize that that virus that's in the nasal pharynx certainly as easily, or create an aerosolization of that. So I'm not going to be as much at risk there than say I'm in my office with topical anesthetic. You know, the patient's breathing, I'm scoping them, they can't have a mask on, so I'm not as protected, I think, in that environment.
There are a fair amount of people that are putting people, or physicians that are doing anesthesia in their offices. I know of about 3 or 4 in my area that are doing that. I'm not personally doing it, but I can tell you that I am sure that their policies need to be appropriate and not less than one would have in the hospital. So they have a lot to do as far as maintaining their PPEs, their burn rate, worrying about aerosolization while they're intubating, waking people up. I mean, there's actually people that are hiring, or physicians that are hiring CRNAs to intubate patients in their office. So I don't intend on doing that in the future, but it's just something I'm bringing up.
Alpen, in our practice for the past several years, we've been doing a lot of in-office rhinologic procedures, including using image guidance, limited FES, endoscopic septoplasty, turbinate reduction, polypectomy, and so on, all under local anesthetic. And we find that patient tolerance, bleeding rates, and things like that are really excellent. But I think to everybody's comments, for those patients, we would want to know that they are COVID negative, tested prior to the procedure, would test them 24 hours or 48 hours prior, or for an ASC, and have them self-quarantine up until the time of surgery. The difficulty is with pediatrics, they come with a caregiver, a parent, a guardian, etc. Do you test the guardian as well? There's so many different variables. And then what does a negative test truly mean if it's 48 hours before? So I think a lot of this is going to be learned on the fly as we go, and we'll get better at what that guidance should be.
Right, and I would just urge everybody to kind of use this as time to kind of standardize an office procedure plan. And we had a huddle today with the idea of actually generating that, because going to Gavin's point, we are actually starting pediatric cases next week. We are testing. It doesn't matter the child's age, we will test them down to infants, and we test the care provider or the person accompanying them, the guardian. We then ask that they then quarantine themselves. We have a return rate of the test in 48 hours, and that they quarantine themselves for 48 hours, and then we go ahead and do the procedure. But I mean, I completely agree with the panel's previous comments about the local environment and the trust of that. I think all we're doing is eliminating the positive patients. It really doesn't do anything different for us to take care of COVID negative patients. And we just need to treat them all. An opportunity for us all to write this up, standardize a procedure, and talk it amongst our team.
Moving into a new facility or has to do something different, either with SMR units or suction and vacuum. We moved into a new facility 6 months ago, and in our former office and in this one, we don't use treatment carts. We have dental suction, basically, which is contained in the ceiling. It's a centralized suction device that exhausts to the exterior, so not changing containers, and the concerns and issues with circulation and exposure are significantly reduced with a dental type suction option.
Sounds like it's state of the art, Gavin. Do you have room for us to bring our patients over?
You're welcome. Be a pleasure.
Chris,
Excellent.
Chris touched on something earlier. Chris, you talked about the anxiety, right, in the healthcare environment with staff, even providers, right, as well as patients. How do we regain the patient's trust and confidence? How do we reassure them that it's safe to come into our practice? Today, I spoke to a lady who I think has benign positional vertigo. She didn't respond completely with home exercises. I've done 2 telemedicine encounters with her, and I want to bring her in for the EPLE. She has 2 young kids, a stay-at-home spouse that's quarantined like she is, or because of the state of Maryland and what the governor's decided to do up to this point. And I had to go through the whole process of what we're doing so that she can have a safe yet effective visit with me. How do we re-engage with these patients so that when the floodgates do open, the patients are willing to come back and see us, whether it's for elective cases or whether it's just an evaluation in the office?
I think a demonstrable effort is the first tool. When they see that we have a screening table in the parking lot. As they enter, before they enter our building, they're met by staff, their temperature is taken, they're asked questions about their recent illness history. And so the very first encounter is for their safety and for everybody's safety. Like some of the other panelists, we are limiting access to the waiting room. We have the ability to text people from the parking lot with our patient notification system. And I have been amazed and really heartened by the percentage of patients, including kids, including the toddlers wearing their little Paw Patrol masks and things. It's great. And amazed how well these kids are doing it. So I think it's the practice culture of safety that they witness when they come in. All the staff are wearing masks all the time. And I think that helps to gain trust. I saw a similar patient, Alpen, with benign positional vertigo that I had done telemedicine. Her husband is deployed. She is home alone with 4 kids, and her BPV started acting up. And she was so thankful to come in for an epi. So I think I think trust will be regained, and I do think there'll be pent up demand that we'll see.
Was she happy because she was able to leave the 4 kids at home?
that I'll discern that on follow up.
Dana, you're getting ready to open up in a few weeks, I assume, in Illinois. Are you planning on doing anything differently as far as having your newer patients or your established patients come in readily without any reluctance or hesitation on their part?
I think patients here have been fairly reluctant to come in, especially, a lot of them kind of say, well, I've had this sinus issue for 10 years. I could probably wait a couple more months. And so, I think at this point, most of my patients have been more comfortable utilizing telehealth. And so I've really kind of made that my mainstay at this point, even going forward when we are going to start seeing patients again in person. I think I'm going to remain in the telehealth world for a little bit longer until people kind of start to regain their confidence and their comfort level. The patients who I would probably be a little bit more likely to insist on seeing are the ones who potentially have sinonasal tumors or cancers that I really need to scope and understand the extent of those tumors. But for the most part, at this point, I'm relying a lot more heavily on telehealth than I ever thought I would, as somebody who likes to scope almost every patient that I see. So it's been a major practice change for me.
One more thought on that. What we were advised and have found very helpful is sharing that information with all the staff and patients. So, we developed a written protocol for the office, staff reviewed and signed off, and also almost like an informed consent for patients. And both of those contain some litigation language, which could be helpful after the fact. Put that on our website and social media and digitally as another method of reassurance and building some confidence and resilience in those patients. And many comment about the value and feeling reassured in that process. And then to Chris's point, walking the walk, when they see those measures in place, that really is the ultimate confidence booster.
Right. And with these extra safety measures that all of us are planning on implementing or already have, there's going to be a practice expense portion to it, right? Whether it's masks, whether it's more gloves, whether it's disinfectants, whatever the case is. So how quickly can we reestablish our cash flow, as many of us have not seen a live patient unless it was in an emergent setting or an urgent setting? How quickly can we reestablish our cash flow for our practice, and how do we go about doing that, especially with some hesitation on the part of some of our patients, and the fact that with telemedicine, as Dana mentioned, we can't do the scopes. A lot of us have suspended allergy testing and or treatment. Rob, you're in private practice, you're in solo practice for a couple of years now. What are you going to do to try to get that cash flow going again?
Well, I've really never stopped seeing patients. I just cut my days. So I've been doing 3 to 4 half days a week. I'm not in the office on Wednesdays. That's my general OR day. And I sometimes used to use Wednesdays for allergy testing. I actually tested 2 people yesterday for allergy tests. So they were part of the 11 or part of the 14 that I saw yesterday or a couple days ago. So when I look at it, I'm just trying to bring patients in when they're comfortable. I'm not pushing it. If you push them to come in and you encourage them to come in, they'll still call you back right before the day before they're scheduled and say they want to push their surgery or their office visit on out. I do have a lot of pent up testing that needs to be done for allergy. I got a lot of backed up audio tests. Even my audiologist, who has been working with me since I began, is very skittish about coming back to work. She doesn't consider herself essential. So if she doesn't consider herself essential, how does she work with aged parents that also live with her? The family's concerned that she may bring COVID back to the family. And again, I think it has to do with screening patients, making them feel comfortable, setting a plan as you go forward. I do have 3 hearing tests scheduled for Thursday. And so I hope that we can get it done and those people will come in. It's really nice to be able to see patients that you're seeing and patients that are coming in after their hearing tests. It kind of mixes things up and it increases the flow. And I really don't know how that's going to work all together with, more than one provider working at one time. So that's something I have to work on. And I think if I'm going to be doing that, I'm going to reserve one of my rooms just to house the post-hearing test patient and the other 2 rooms to work patients through the workflow. So I encourage patients to come in. It's very hard to have people come in and consider their problems more urgent when the governor still has the state lockdown. We have official lockdown till the end of the month. So I don't think that my business and all my pent up patients and all my backlog is going to start relieving itself until the governor says that we can open things up in more of a manner that we have. So,
Wes, any thoughts on how we can, months of being idle essentially, bring back our revenues to help offset our expenses, whether they be related to HR expenses or rent or mortgage or whatever the case may be?
Yeah, so, I feel like now we're in this pandemic age, right? And who knows how long this is actually going to last. And how are we going to have to change or alter our previous workload and workflow to make it functional and feasible to continue moving forward? I mean, if we have to continue social distancing with our patients and or with our staff in our offices, my office isn't that big to see as many patients as we put through if we have to keep everybody 6 feet apart, right? So I think there's just going to be changes in schedule that have to continue until we feel like it's safe enough for it not to. So I don't feel like we're going to necessarily jump right back in a month or 2 to where we were at. I just don't see that happening. But
Gavin or Doug, are you guys thinking about adding any other ancillary streams of revenue that weren't part of your practice previously, or maybe extending hours to weeknights or weekends if you weren't doing that beforehand to help boost the bottom line?
All of the above. Well, let's put it this way. I think, and the pain point is yet to come. When you consider the cost of providing care for so many different reasons that you've had to modify your office and your workflow and PPE, cost is going to be dramatically increased. Efficiency and reimbursement is going to be reduced. And so as we get 90 and 120 days into AR, and that accounts receivable becomes depleted, that's when it's really going to hit hard, because expenses and PPP loan and all of those aspects, you know, are all coming due by June 30th. And so I think it's going to be a slow process, and it's not going to be like flipping on a light switch. It's going to be more like a dimmer, as everybody's pointed out. So we currently provide all the different ancillaries that one can, but you know, for those not providing point of care CT, while it is an investment, that's an option, but it's a slow ramp up. This may be a time we're considering having the conversation about pay for call with our system, and certainly extending hours and Saturday morning hours, including the ASC when that gets running. But it's a tough, slow ramp up, and it's going to be very hard to scale back during the recovery to pre-COVID rates.
Chris, how are you handling reboarding of staff? I know several of us were fortunate to have the SBA, or Small Business Administration, Paycheck Protection Program loan, which helped float the practice for a few months and helped offset some of the staff expenses, right? But moving forward, do you reduce your staff? Do you bring them in at different times? Because as we know, even when we reopen, patients aren't going to be coming in at full capacity, and it's going to take some time to buy in and engage these patients. And we're going to have to figure out the kinks and the workflows and the processes. But any thoughts on how you're approaching one of our biggest expenses in practice, which is the HR component?
Sure. Personnel is always, you know, a big part of our expense profile, and we were fortunate enough to obtain the payroll protection plan, and certainly that has allowed us to maintain the entire staff. We've not had to furlough anyone, and we did late March adopt a 2-team strategy. So we've reduced the staff to Team A, Team B, and we're alternating weeks, just in an effort to minimize exposure. I mentioned we had 3 geographic sites, and previously we rotated amongst those sites, kind of a 3-man weave, so to speak. But we've limited providers to a single site, so there's no inter-site transmission. And our plan is to maintain the A and B team through the end of this month, with the hope of, if demand is there and if our local resurgence rates haven't been severe, to try to get back to full staff next month. And that's just a moving target. In response to your previous question too, I think I'd be remiss if I didn't observe that Allergy has been perhaps the most resilient part of our revenue stream, to the extent that we've been able to safely provide it. And I think that we will find Allergy will help us ramp up as we begin again. Patients that are already established with your practice and have a history and have a comfort with you will be more likely to come in than new patients who don't really know you and who are reluctant to venture out for care. Like Dana said, they've been putting off for a little while. They may continue to put it off. They've already been receiving allergy immunotherapy. They benefited with that. And oh, by the way, this hit right during the middle of our worst pollen season. I think we'll see that flow of patients return the quickest.
And I would just echo that I think Allergy is the most resilient. And I would offer that the AAOA is doing some things to try and help. Look at our website. I think there's going to be a lot of good content that's going to be offered to help you engage allergy patients. And I agree with Chris. I think they certainly, in my practice, have been the most resilient. I only paused in immunotherapy for 2 weeks and then resumed that with the recommendation of some national organizations, including the AAOA. There are some content that's on the website about restarting immunotherapy. If you pause, if you need some of that information, it's readily available. We've worked hard as an organization to keep up with that. So I just want to get that self-plug, and I appreciate that. And Jamie Lucas, I expect to have a $20 check in the mail. Thank you.
But to put an exclamation point on Chris and Doug's comments, I mean, the value of providing that allergy care is just phenomenal to see how well these patients do. But truly, in my opinion, over the past 20 years, it's absolutely the best ancillary service you can provide from a clinical patient satisfaction point of view. But from a revenue ancillary, undoubtedly, in my opinion, a wonderful ancillary that'll help get you through any crisis. You know, they say medicine is recession proof, but nobody could plan for this. And one could continue sublingual immunotherapy through the crisis. So if you're not doing allergy immunotherapy in your office or testing, the AAOA and the AAOA certification process is a must.
So before we conclude this very stimulating conversation, I want to go around the squares here and maybe have each of us present maybe one key takeaway for the audience or one summary point. We'll start with Dana, something that a pearl for our audience as we talk about jump-starting our practices.
Yeah, so I think a lot of what we've talked about tonight is that, you know, this is not a light switch that we can just turn off and on, and this is not going to just magically go away. So I think having a plan and thinking about all of the things that we've been discussing tonight and how they most appropriately apply to your practice and your area, so that you can prepare and you can continue to provide the care that you've always provided for your patients moving forward, so that you just have a strategy so you don't get stuck. I think we were all kind of just blindsided by this and hadn't thought of something like this and didn't have a plan laid out. But I think what this has done, it's allowed us to kind of take a step back and realize we do need to have a plan. So if this is going to continue, if there's going to be a second wave, I think that this has allowed us to have a plan moving forward.
Doug?
I think there's going to be a lot of goodwill towards medicine and towards healthcare in general. I know one of the oddities of this is I got a donation of N95 masks from a local excavating company that uses those N95s with all their big equipment. And so some unusual kind of help has come from unusual places, I should say. And then to echo what Dana said, to have that plan of action should this happen again or when it happens again, and having some, we even have it so far as we've scripted with our front office to try and let patients know what we're doing and how we're providing care, and letting them know that if they're not comfortable, we can do virtual care and those kind of things, and just scripting it on out as part of the process for entry into the office. And that can be something that really bears dividends.
Gavin?
Really just to echo the sentiments that have been expressed, and to say that fortunately in the United States, there are less than a handful of otolaryngologists who've been stricken, and most not directly through patient contact. We've all probably been seeing patients asymptomatic positive since January through March. Hopefully we're a resilient workforce. The American public are resilient. We'll get through this all together to continue doing the good work that we do. And it's made easier by taking care of each other. And I think we need to take some time to take care of ourselves and our families in the process, so that we can take care of others.
Rob?
I think in this COVID era, we need to use our time wisely, step back, rethink why we became otolaryngologists, why we do the things that we do, appreciate the fact that everybody else is going through it, that we're not the only ones that are having to work through this, and know that there is an end and things will get better. So as long as we keep each other safe, our patients safe as we can, our staff as safe as we can, that that's the best that we can do. At the end of the day, you can say you've done your best, you know, then that's pretty good. So continue to soar to be the best, help your patients out the best you can, and keep everybody safe is what I would say moving forward. And continue to lean on your friends. Ask them what they're doing. Pick up a call, pick up a phone, call them, let them know that you're also thinking of them. It's really nice to hear from other colleagues.
Wes?
Well, it's nothing like a crisis to either pull us apart or bring us together, right? Especially in your office. So that's been pretty evident. So communication, and I can echo just what Dana said too, to have a plan. But what this has done for us is, we talk about our plan for the day every day, whereas in the past it was all just kind of rote, and we didn't really think about it. We all just went around our daily business because it was routine. This is not routine, so it's certainly helped us to figure out how to work together as a team. So that's what I recommend. Keep trying that.
And last but not least, Chris.
So just 3 takeaways. As we said, don't discount the anxiety component on your staff as you ramp back up. And as the staff feels comfortable and feels protected, that'll create a culture that will transmit that protection and comfort to the patients, and it'll help the patient feel more comfortable. Secondly, in the midst of crisis, there is opportunity. And, as Rob mentioned, there's time to reflect, there's time to think about things that opportunities that exist, what we can do better. And so use this time that we have for that. And in that vein, if you're not doing allergy, or if you have a limited foray into allergy, consider exploring that more. As we've said, it's a very resilient part of the revenue stream. And then, lastly, moving forward, I remain confident that our business model is sound. There will be continued demand for our services. We'll move forward haltingly at first, bootstrapped by new PPE requirements and additional safety concerns. Our flow will be less efficient, but we will move forward. And I feel like we will emerge from this better. Many of the PPE precautions, really will help protect us and keep us safer in the future. Yes.
Well, I want to take this opportunity to thank the panelists, all of you again, for the great conversation today. I really learned a lot as well, and I'm sure our audience will find this Zoomcast on jumpstarting your practice very useful. I want to thank the audience for listening into the AAOA Zoomcast series. We have our first AAOA virtual course being launched in the next month or two. So be on the lookout with emails on registration for that course. You'll have an opportunity to learn more about rebooting your otolaryngology, allergy, and rhinology practice, as well as reinforce core allergy and rhinology concepts. The name of the course, Core Allergy and Rhinology Concepts, the Age of Pandemics and Beyond. Thank you, and see you next time.